On behalf of my co-authors, I would like to thank the organizers for giving us the opportunity to present today the EFS sensitivity data and further subgroup analysis from the KEYNOTE-522 trial. Please note my disclosures. Pembrolizumab showed anti-tumor activity and manageable safety in metastatic triple-negative breast cancer, especially in the first-line setting. We also know that neoadjuvant pembrolizumab and chemotherapy have shown manageable safety and anti-tumor activity in early triple-negative breast cancer. Therefore, KEYNOTE-522 was set up as the first prospective phase 3 trial of pembrolizumab in early triple-negative breast cancer in both neoadjuvant and adjuvant settings. The primary results showed statistically significant and clinically meaningful improvements in PCR with neoadjuvant pembrolizumab and chemotherapy, and also in event-free survival with neoadjuvant pembrolizumab and chemotherapy followed by adjuvant pembrolizumab. In KEYNOTE-522, adult primary patients with previously untreated stage 2 or 3 triple-negative breast cancer were randomized 2-to-1 to neoadjuvant pembrolizumab at a dose of 200 milligram or placebo every 3 weeks, both given with 4 cycles of paclitaxel and carboplatin, and then with 4 cycles of doxorubicin or epirubicin in combination with cyclophosphamide. After definitive surgery, patients continued adjuvant pembrolizumab or placebo every 3 weeks for up to 9 cycles. The trial had dual primary endpoints, which were path-CR assessed by the local pathologist and event-free survival assessed by the investigator. Secondary endpoints included overall survival among all patients, efficacy endpoints in patients with PD-L1 positive tumors, and safety. We also performed pre-specified sensitivity and subgroup analysis to assess the robustness and consistency of the primary event-free survival results. A total of 1,174 patients were randomly assigned to treatment, with 784 in the pembrolizumab group and 390 in the placebo group. At this point in time, the median follow-up is approximately 39 months. The full baseline characteristics were previously presented and were as expected and well balanced between the 2 treatment groups. Shown here are the baseline characteristics for the subgroups presented today. The primary EFS results of KEYNOTE-522 show a statistically significant and clinically meaningful improvement in event-free survival with neoadjuvant pembrolizumab and chemotherapy followed by adjuvant pembrolizumab. 60% of the pembrolizumab group and 24% of the placebo group had an EFS event. The hazard ratio was 0.63. In the primary analysis, event-free survival events were local progression that precluded definitive surgery, distant progression, local or distant recurrence, death from any cause, positive margin at last surgery, and a second primary, which was non-breast cancer. Patients who did not experience an event or who started new anti-cancer treatment were censored at the time of the last disease assessment. In order to evaluate the robustness of the EFS endpoint, 5 pre-specified sensitivity analyses for event-free survival were performed. Since disease assessment is performed periodically, a new adjuvant anti-cancer therapy may start post-surgery. Analysis 1 and 2 assess the impact of different censoring rules, considering missing disease assessments or starting new anti-cancer therapy. As the event-free survival definition contains multiple components from pre- or post-surgery assessment, analysis 3 to 5 assess the impact from those different components. Specifically, we looked at positive margins at last surgery, which was not considered an event in analysis 3. We looked at positive margin at last surgery and second primary non-breast cancer, which were both not considered events in analysis 4. And we looked at second primary breast cancer, which was considered an event in analysis 5. The benefit of neoadjuvant pembrolizumab and chemotherapy followed by adjuvant pembrolizumab versus neoadjuvant chemotherapy alone was consistent with the primary EFS results in all 5 sensitivity analyses, showing the robustness of the event-free survival benefit in the pembrolizumab arm. Analysis 1 was, in my opinion, of particular interest as it considered the impact of post-surgery new anti-cancer therapy, for example, the use of adjuvant capecitabine. As you can see, in the pembrolizumab group, 31 patients received adjuvant capecitabine. In the placebo group, 13 patients received adjuvant capecitabine. These patients were censored before the start of adjuvant capecitabine. Recall in the primary EFS analysis, 60% of the pembrolizumab group and 24% of the placebo group had an EFS event, and the hazard ratio was 0.63. Now in analysis 1, 14% of the pembrolizumab group and 21% of the placebo group had an EFS event. The hazard ratio was 0.64. Thus, the difference between treatment groups in EFS in analysis 1 remained consistent with that of the primary analysis, indicating that the treatment benefit with pembrolizumab was not due to non-protocol anti-cancer therapy. Analysis 3 was also notable, as it removed positive margin at last surgery as an EFS event. Based on this analysis, 60% of the pembrolizumab group and 23% of the placebo group had an EFS event, and the hazard ratio was 0.65. Again, EFS remained consistent with that of the primary analysis, indicating that excluding positive surgical margins from the EFS event definition did not influence the conclusion of the primary EFS analysis. The number of patients with positive margins was small overall, and those patients continued to be followed for other EFS events. Of 16 patients with positive margin at last surgery, 12 had local or distant recurrence later. In addition to the robustness of the primary EFS results, as shown by the sensitivity analyses, the subgroup analysis revealed consistent EFS results in pre-specified subgroups defined by nodal involvement, disease stage, menopausal status, HER2 status, and LDH level. As expected, patients with nodal involvement in both arms had poorer outcomes than those without nodal involvement. Nevertheless, patients in the pembrolizumab group still had improved outcomes compared with placebo, suggesting that pembrolizumab provides benefit regardless of the nodal status. Similarly, we see that the EFS benefit with pembrolizumab was irrespective of disease stage. These results are in line with previously presented EFS subgroup analysis from this study that showed a treatment benefit with pembrolizumab irrespective of tumor size, highlighting the importance of early intervention. At the time of data cutoff, all patients had completed therapy. As we previously demonstrated, most side effects during the chemotherapy phase were dominated by chemotherapy, with the most common side effects being nausea, alopecia, and anemia. In the adjuvant phase, the incidence of severe side effects was very low, with 6% and 3% respectively. If you look at immune-mediated events, they were more common in patients receiving pembrolizumab. 44% of patients in the pembrolizumab group and 22% of patients in the placebo group had an immune-mediated event or infusion reactions. Again, in the adjuvant phase, these immune-mediated events were rare. 10% of patients in the pembrolizumab group experienced an immune-mediated event compared to 6% in the placebo group. In summary, a statistically significant and clinically meaningful improvement in EFS was observed with neoadjuvant pembrolizumab and chemotherapy, following by adjuvant pembrolizumab. The treatment benefit with pembrolizumab on event-free survival in each sensitivity analysis was consistent with the primary analysis, showing the robustness of the primary EFS results. All subgroups appear to derive a comparable event-free survival benefit, including those by nodal status and disease stage. The rate of adverse events with pembrolizumab was low, especially in the adjuvant setting. These results further support pembrolizumab plus platinum-containing neoadjuvant chemotherapy, followed by adjuvant pembrolizumab after surgery, as a new standard of care treatment regimen for patients with high-risk, early-stage triple-negative breast cancer. I would like to thank the organizers again for allowing me to share these results from KEYNOTE-522 today. On behalf of my co-investigators and the study sponsor, I would also like to thank the patients and their families and caregivers for participating in this study, along with site personnel at all enrolling centers. This study would not have been possible without them. Thank you very much.